Hi everyone, welcome to a Couple Nurses episode 113. Thank you guys for tuning in. We appreciate you guys for listening, downloading this episode. If you guys find value in this episode, please share with your family members, loved ones, friends, nursing students, colleagues, anyone. We would appreciate it. And it gives us, motivates us to keep on producing high quality content. What's new? CoupleNurses.com for show notes. We are Frontline Warriors. Merch is coming soon, just like we said. We're building out the infrastructure and little updates on the personal life. Our contract is wrapping up. We're going to take a break from travel nursing. It's been a long, few months just grinding nonstop, podcasting, trying to vlog. So we're going to do a little RV trip for 2 weeks and just unwind from the work life.
Yeah, it's going to be fun. I've never taken an RV trip before. So it's going to be such a crazy adventure for 2 weeks just in an RV. It's going to be so fun.
And it's cool because we're travel nursing and we're constantly breaking these barriers of the comfort zone. It kind of always puts things in perspective. You're always appreciating things. You're always kind of catching yourself with bad habits sometimes.
Right.
And it's going to be nice to just camp out and chill.
Right, yeah. So from our perspective, we started travel nursing in October. And our contracts, we did travel nurse from October all the way up until June. First week of June. And then we're taking an RV trip for 2 weeks after that. And we're coming back to Chicago mid-June till end of June. And then we're taking 3 months off. And then we're going back to travel nursing. We literally are just taking 3 months off.
Isn't that
we're
nice?
Just gonna be chilling and then working on stuff.
Yes, and that's going to give us time to work on everything we want to do with Frontline Warriors, the podcasting, getting better guests and all that. There's only so much you can do in your day.
Right.
I just came off of 3 in a row and I'm sitting here and I'm podcasting, so it's fun. The grind is exciting. And one cool thing about travel nursing is we could take this 3 months off. How's nursing? How was COVID? It's been busy, right?
Yeah, it's been rough. I mean, it's been fun though. It's definitely been an interesting experience. It's been a good experience. How often are you going to be a nurse through a pandemic, right? So it's just crazy to see all the changes, and we're gonna be able to see how things are now gonna be implemented in a different way. We'll see how the masks are going to be in a hospital, see what kind of procedures are going to be brought up, just medications, all that.
One thing which is constantly changing is visitation policies. In DOU, which is PCCU, visitations are from 7 to 7 or whatever, and the ICU it's
9 to 7.
9 to 7, and the ICU it's 11 to 7, and it's constantly changing. California on June 15th is announcing no masks or whatever publicly, so they're changing visitations again. There's just so much regulations changing. It's so hard to keep up with the information.
Yeah, it's definitely wild, but it's cool to live through this. But let's get with the episode.
Let's go.
So on today's episode, we're going to talk about the differences between nursing school and actual nursing. Usually the first thing new guy hears coming out of nursing school is actual nursing is a lot different than theory and clinical and everything you basically learned in nursing school. So we're going to outline some pretty key points and things that we were taught in nursing school that we don't really do that often anymore.
Yeah, and it makes sense because when you're a nursing student, nursing school really just prepares you for the first year of being a nurse. You just learn the orientation part and the basics. The most experience you're going to learn is when you're actually doing the nursing post new grad. So it's important to make sure you have a good orientation, at least 6 weeks.
Yeah, usually when you Google things online, how nursing school compares to actual nursing, the main thing you're going to basically see is nothing's textbook. Nothing is ever textbook. And it's just complicates a lot of things in theory. But the one thing that I found funny is when I was looking through these things is G-tubes was number 1. So when nurses were asked what's the biggest difference between nursing school and actual nursing is G-tubes. Because in nursing school, you're supposed to crush each med individually, flush the G-tube in between the meds, and then mix the water individually with the medication and flush that through. Without flush in between.
Imagine how long that would take for every single patient if you have multiples.
Yeah.
So the reality is you just mix it all together.
Right. It's all going to the same place. And no one really has time because sometimes patients have 12 PO meds or through the NG tube or G tube, and then you gotta give 2 or 3 pushes, and then you gotta titrate meds, and it's just you don't got time for all that.
What's accurate though is make sure you're actually flushing the 30 cc's before and after. Because if you don't do it before, sometimes it'll clog the tubing, especially the Dubhoff, the skinnier ones, and push afterwards.
Right.
The worst thing is when you clog a tube and you gotta troubleshoot it, or for nurse, you have like a tube that's like not being run for a couple days, and then you try to flush it, just stuck. You gotta use Coca-Cola or something.
Yeah.
So that's one little hack in nursing. You might be doing the Coca-Cola. Sometimes you might take the guide wire. Some nurses save it, and you could thread it through sometimes to unclog specific areas. Not textbook. And another thing about G-tubes is the whole placement thing with the stomach. Like, that's not the gold standard. That's not the definite is always an X-ray.
Like with the air you're talking about, right?
Yeah.
Like checking patency with like airway listener or stethoscope.
I still do it.
I do it all the time, yeah.
Because you're supposed to, just to make sure. Mm-hmm. If you get the lung, I mean, you're gonna be desatting. The patient's you're gonna know that something's up, or that's coiling somewhere. Like, you're gonna figure it out.
Right. Have you ever pulled one in a lung by accident before, or like the trachea?
I'm trying. No, I don't think so. I think one time it coiled in like an awkward spot, or didn't make it through the throat.
Yeah. But
never into the lung.
Yeah, I've seen what happened. I'm pretty sure I've done one before. Yeah, they just desat right away. You just pull it out.
Okay, that's it. Imagine, God forbid, you push water through, you get like pneumonia.
You gotta be careful.
Really unsafe.
You gotta make sure that thing's in, and like you can't just like forcefully push through. There's like some technique involved in it. But that's just changed over time. And even so, what kind of Dubhoff did you guys use? Because at one point, I believe our hospital was using like these things with these like black ends. I think it was like a magnet or a little weight, and it's supposed to be better than like the standard ones.
So that's what I've been used to as well.
Yeah, really?
And before you set it up, you're supposed to flush it with like 10 cc's to prime it.
Yeah.
And you don't have to use petroleum jelly for those because the tip was already lubricated. It lubricates itself when you flush it.
Yeah,
those are efficient.
Okay.
And those things also have like the new safety valves. So when we were in Oakland, I think we told the story before live. Go again I think there was a nurse that somehow jerry-rigged the tube feeding and put it into the peripheral.
Oh yeah, that was local.
And killed the patient, right? So a lot of these hospitals now, they're just developing these lure lock systems for these NGs. So yeah, I find it safe. I just find it so much easier where you can just like do a regular NG. It's very simple.
Right.
It makes my work more efficient.
I'm very interested on how that happened, how somebody was able to attach NG tube feeding to a central line. Like how? Like imagine how much maneuvering that took. If something is that complicated to attach, it's probably not the right way.
Exactly.
You know what I'm saying?
Maybe she thought it was TPN. I have no idea. That's unsafe nursing.
Right. Yeah. What if she? Yeah, that's wild.
So the next one is Foley catheters. So what about it?
Man, those things suck sometimes, man. Like for dudes it's easy because there's only one hole, but then so for some females it's just hard to do. Like for me, when I do a Foley, I always gotta bring an extra one with me, because I'm like accuracy wise, I'm like 75%. So it means if I gotta put in 3 Foleys this month, I'm probably gonna miss the next one, So I'm always ready for that.
I'm thinking about, I have a scar story when it comes to female Foley catheters. One time when I started as a new grad, we had to put a Foley catheter and I couldn't get it myself. It was like this, it was a nun. And she had vulva cancer, whatever it's called, vulvulus, of the labia. And it was so bad, man. Like, I'm scarred right now thinking about this.
Dude, poor lady.
And it's also funny because today one of the techs was helping me out, and he's a student nurse at the hospital where we work. And he said, you know what sucks when it comes to male catheters is fat, uncircumcised men.
Oh, shit.
And I'm like, oh, okay. I'm like, yeah, you have a good point. There's a lot of damn skin.
There is.
And then he's talking about, because he's a student nurse, he's like, how are you supposed to, use the second hand and break sterility and still hold it? And I'm like, that's so funny.
Somebody's got to get it in. To get it in and get out,
So, yeah, it's just never pretty, even though the way the instructors kind of teach you in school.
Never textbook. Like, even with the IV pushes, which is the next point, is some meds they teach you to push over 5 minutes or push over 3 or 2. No one's really pushing Lasix over 5 minutes. It's probably 30 seconds, a minute if anyone's
we're giving
time.
We're not giving advice on how to do things. By the way, guys, we're not telling you guys to push meds.
Yeah, push it in
30 seconds instead of 5 minutes. Disclaimer here.
Yeah.
But in reality,
if you want to run it through IV tubing, what's going 10 cc's an hour just to be safe, you could go do that too, or whatever you want. But I'm just saying, some nurses don't have time to do those kind of things, which is okay.
Even like
As long as you feel safe doing it and it's in your patient's best interest.
Even like programming pumps. So like when I was in U-Grad and I started at my first hospital, we always programmed everything, even like albumin.
Yeah.
And when you start going to like different hospitals and travel nurses, you start realizing like things are done differently. When you go to a different place and all of a sudden you're not hanging albumin over 2 hours, you're just like spiking a bag and it's flowing to gravity. I'm just like, whoa, I've never done this. And it's like taboo because we're taught this way, but that's how things go down.
Yeah, like a pressure bagging
or
blood
pressure bagging blood in this hospital just because blood tubing's on back order for 6 months since COVID. It's just, that's the Wild West. It's the reality of nursing. Like, you're supposed to, prime it at 125 cc's an hour, so that the patient's doing, and then maybe go up to 150, 175, 300, and here you're just bag flowing it. And one time I caught myself, the bag went in like 45 minutes. That's pretty quick. But how you're supposed to know? It's like
super hard time.
Like, think about this. You know how like in nursing school they teach you the drip rate? Do you think I'm gonna stand there with my watch and like stand there for 60 seconds and count 60 drops of blood while there's shit going down, like monitors, someone's screaming dementia. Help! Oh my gosh, man! Like it's not feasible.
It's not, and that's just how it really is. And that's a good perspective to bring up because not a lot of people know that, and it's just how the real world of nursing is. It's not ideal in every situation, and no situation is ever ideal. There's always stuff going on, and you're always not necessarily cutting corners, but trying to figure out the most efficient way to do these things.
You do.
But of course, safety is still number one, and it just works. It just flows, and it's just the understanding. So, like, the next thing that you not to do in nursing school is to never, like, discontinue or modify physician's orders without first speaking to them. Like, there's protocols in the hospitals, and you have a relationship with certain practices where it's okay to order certain meds or certain labs under their name. Like, for example, you wouldn't need to necessarily page out to renal to ask for like a creatinine level, right? For the morning, or a BNP, you just put it under them because obviously nephrology is seeing them or renal is seeing them. They're obviously want to see those labs in the morning.
Or for example, you hang blood, and you know it's usually standard 1 hour afterwards or 2 hours. Get a CBC. If the physicians forgot to do it, I'm not gonna call about something ridiculous like that.
Especially at night.
Especially at night, and you learn. That's what's so cool about nights is you learn that you know what to call for. If they forgot to put morning labs in, and you're in the ICU and that patient doesn't have a CBC and a BMP, that shit's standard. But every single patient should have one. They're in critical care, so you just like start learning these habits with experience, and you don't bother a doctor for acetaminophen 650 milligrams for a patient.
All right. Yeah, and it's like cool because like some floors have some pretty neat autonomy, where let's say the patient came, he's like a new admission, and he's got a history of like dialysis or he's got history of like low electrolyte or something. Physicians are going to be okay with you to put in like potassium protocols or magnesium protocols just because they already know that this is a renal patient. But what they're going to add on to the order usually is to first look at the creatinine clearance.
Yeah.
Right, because your creatinine has to be at a certain number for you to properly excrete fluid and electrolytes. So if you have a poor creatinine function, well then that potassium is going to stay in your body longer. So you might want to give a 20 milliequivalent instead of a 40.
I feel like we also introduced this topic like we shot the gun here. We took 2 steps. One step would be saying, in nursing school, doctors put all the orders in. And it's never a damn thing. You're always putting in orders. And sometimes the doctor hangs up and you're just like, oh, okay, well, it's this med, but what's the dosage? And it gets so annoying. I wish it was just a standard where doctors always did it. And I bet there's nurses out there that are listening and, my physicians do it. That's great. I'm so damn jealous. Yeah. It happens all the time. Or you're just talking, especially now on day shift, and then verbally they're like, okay, let's do A, B, and C. And it's your responsibility to spit that back to them. Okay, I'm confirming I'm giving this. Because at the end of the day, they'll just walk away, and then you're going to be the one that has to page and follow up because you forgot one small thing. Like, is it 3 milligrams or is it 6 milligrams? It's that important. You better remember those details and ask.
Right, and nights makes you remember is hardcore. Because it takes only a few times to getting yelled at or bitched out by a physician.
Especially,
because you
especially
call
those that
something
hang up
dumb.
quick.
Yeah.
Yep.
And they even answer a question, is a hang up. Like, it's like, hey, you should know this by now. You've been on this unit, you should know this. You're on this unit, you should know this. But not all physicians know that, hey, nursing turnover rate is pretty high. So the likelihood of that being the same nurse each time is not very likely.
And that's what sucks. Like, you're a nursing student and we work nights and you get bad mouth from physicians sometimes.
Yeah.
And it discourages you. It kind of makes you sometimes not want to, like critically think about everything about your patient, because then you're just like, damn, I got to call. Like, you always advocate for a patient. I'm not saying don't. That would be talking about nursing malpractice or negligence.
Yeah.
Always do everything, but it's just annoying when these physicians don't respect nurses.
Yeah, it sucks. I mean, there's like certain things in place, because there was a unit that I was on, or some point that there was an issue between like the physicians and the nurses, and there was such toxicity that they wanted to get rid of one certain physician because it was that bad. It was like that guy was facilitating the issue. I don't know. I forgot if that was in Oakland or somewhere.
Imagine the power trip we had.
Yeah. So I'm not sure what happened, because I think it might have been in Oakland. But whatever. So that's like a crazy dynamic to be part of. Imagine how less of quality patient care is probably happening like in one of those units.
And I've experienced that like in my previous employment, where this heart surgeon just wanted to have specific cardiac nurses taking care of his hearts, and he wanted it in this one hospital because it's prettier, nicer compared to the other one. And then those nurses had to like drive to the other hospital. They didn't want to. It was only like a 5-mile drive, but still.
Still, yeah.
So it's just.
They get reimbursed?
No.
Oh man.
I know, and they didn't even give like a bonus or anything. So it's annoying because yes, the cardiac surgeons always bring the most money, and they're these stakeholders that could just kind of swing around and upset nurses. Or it could be just like bad management. I remember working nights, there was a day shift manager, supervisor that just like ruined everybody's mood. She just like tore you down for some reason. And yeah, you're just talking about toxic culture. We don't need that. So just a quick little interview tip is like, if you're applying for jobs, always ask about the culture.
Right.
Or if you're getting interviewed by the nurse that's on the floor, ask about the culture.
That's a really good point you bring up, because when I was applying to jobs or just working anywhere in general, like for my nursing career and stuff, I never asked about the culture. I wish I did.
About it.
Yeah. I mean, the culture where I used to work was great. It wasn't bad, but I'm saying it's a good thing to ask, because now going through different units and hearing about other units from other nurses, from social media or just talking on the unit, like there is really toxic workplace cultures where people don't get along with each other and just can't communicate properly, and it sucks. So imagine how horrible that's a horrible work environment, and it's probably a bad place for patient care. So it's crazy to think about that.
I know. What the next one is patient compliance.
Yeah.
So textbook, you educate the patient gets discharged, and it's a fairy tale.
They're good. They're living great. The guy just came in for a quadruple bypass. He's gonna adhere to his heart healthy diet.
Yeah, he's gonna eat less than 2,000 milligrams of sodium.
He's gonna exercise.
He's gonna weigh himself daily.
He's gonna decrease stress.
Make sure you take the 20 milligrams of Lasix.
He's gonna take off a workload. He's gonna be hanging out. He's good.
And no, man, these patients just come 3-4 times. And in like half of your time, I'm trying to think of a time frame, they're frequent flyers.
Yeah, and sometimes these people, you see them, when they leave the hospital, they're decent condition. Like they could pull through. Like it's not, they came through a lot, but they could pull through. And they come back 3 months later and they're complete shit.
Isn't it so sad to see how people don't take accountability for themselves and they just self-neglect themselves to that ability? Like you see patients sometimes in 3 months and 6 months, and you're just like, wow, this person changed or gained weight, and especially like the CHFers, you just come in with like these swollen, weeping feet sometimes, and or could barely breathe. Like you go on, they go on BiPAP for CHF exacerbation or COPD.
We had a lot of frequent flyers when I used to work with the LVADs. Like
and you've seen the
worst. Just like damn. I mean, LVADs did do a lot of benefit for certain people, but sometimes, it goes south. Like the surgery goes good, but someone doesn't happen properly. Genetics get involved, random events, the machine malfunctions, and we're in a hospital, so we see the worst of the worst. Especially with like LVADs, if it's put in one hospital, it's usually where they're gonna go for their full care for the rest of their life.
And we see such a small minority of people too, like in the world or in the patient, the cities.
Yeah.
And it's just it's sick of the sick, so it just always it's humbling.
Yeah.
Next one, which is double gloving.
So
in
what
nursing
kind of double
school,
gloving are you talking about?
double gloving, the safety, man. It's always about the safety.
I feel you, man.
Both gloves.
It's like gloves we're talking about. It's like gloves on your hands, people. The gloves on your hands. So yeah, in nursing school, you're always told to put on some gloves, do the dressing change, take off your gloves, put on new gloves, then apply the other dressing. If they get dirty during that point on, guess what? You gotta take them off, put new ones on until you get it completely right. Here, in the real world of nursing, double gloving or triple gloving, definitely the way to go.
Especially if you're cleaning up poop.
Especially if you're cleaning up poop. Like that's probably like nursing advice 2.0 right there.
And even with like COVID, for example, you learn the trick if you put two gloves on, you take off one pair, the other one are technically still clean, you can put some hand sanitizer on, and then you can take your PPE off or wipe down your equipment. True. So it's almost like it saves you time in a way. Mm-hmm. So yeah, it's like you're going to double glove.
I wonder what the reason for non-double gloving was.
I have no idea.
Right? So you gotta take out the gloves, and then they're probably gonna make a hypothesis that at some point your gloves are gonna get dirty before you put on the new gloves. Right? I guess that's a theory. Probably the most logical theory I can think of.
Yeah, even with the surgical ones, sometimes you might double glove over your regular gloves.
Yeah.
If I'm in a COVID room, I don't want to take off my gloves and expose my hands, maybe.
Right. Yeah, that's good stuff. The next one on the list is the wet to dry dressing changes. I feel like in nursing school, these were over practiced. There's so much more dressings that we do that are not wet to dry dressings. Wet to dry dressings are probably they are an older method of to do certain things that we have different ways to do now. We have different foams for different things. We have wound vacs for different things. We don't necessarily need to do wet to dry. We have more efficient and better methods to do things.
And I've usually seen them in like the wound debriefments. Debridements.
If you get about the Instagram debridements.
Yeah, man, good old Patreon videos. I've seen it with a few surgeons usually do that, but usually there's so much advanced technologies now. You have silver, you have the Duoderm, Xeroform. There's so many different dressings that promote wound healing and have all these antimicrobial properties. Wet to dry is really non-existent. Right. I have not dealt with it for probably over a year for sure.
My patient had a wet to dry, but the thing, I feel like when you see a wet to dry, if they're not 100% sure what to do yet, I feel that's when it's a good time to do a wet to dry. If you're not sure how we should treat this, let's put a wet to dry on there.
Just to be safe.
Yeah, change a Q shift or daily, and then we'll see what happens, and then we'll talk about it, take a few pictures here, take a few pictures there, and then we'll figure out how it heals and what we do.
I just thought about it. So here in this hospital that we work at, the trauma patients do wet to dry. Because they probably don't know what to do with the trauma patients too. It's very severe. You don't know how this is going to heal.
Yeah. Makes sense.
For example, for like the external fixators, they were using Xeroform. Antimicrobial properties.
Yeah, respect.
There's wet to dry. I wanted to cover more about it, but it's not really.
Like we do it sometimes, but not as much as we thought we were going to in nursing school, right? Because there were days where you're at home practicing for your professor to watch you put on sterile gloves and do a wet to dry dressing. Did you do that? Was that one of your?
Yeah, it was a sign off.
Yeah, it was a sign off. So you had to pass that to move on, right? But you don't do it that often. There's other stuff that nurses do more than that. Like some nurses probably would have benefited from learning how to wipe ass before becoming a nurse. Because some nurses don't know how to clean the patient properly.
That was me, man.
You know what I'm saying?
I was a forklift operator, and it was a complete culture shock going into it.
That probably would have been more beneficial to you than learning how to do a proper wet to dry without double gloving and everything like that. You know?
I agreed. The next thing when it comes to the real setting, they don't teach in nursing school is the NCLEX teaches you this perfect environment of being a nurse, and then you understand that nursing is not black and white, and one of them is short staffing. We in California we're blessed to go, to have ratios during COVID, they went on ratios at some hospitals where we worked as travelers. We're lucky that we barely went over. I never got like triple or anything in the ICU. So you're going to be short-staffed. It's going to happen both days, both nights. Like there's turnover rates. People are burnt out. COVID happened. People are called off because they can. They have like, 3-4 shifts, so whatever the pay period it is. And you're going to be faced with having rough times.
Yeah. I think at all nursing school, we probably talked about short staffing or how to deal with stress in the work environment. And not that cheesy stuff where just like, these are steps to good communication, not that stuff.
They teach you leadership.
But the actual like how to properly communicate, how to actually deal with stress and short staffing, we probably did like maybe one class about that. Nobody tells you how short staffed you're going to be as a nurse. And we were short staffed before the pandemic. Before the pandemic, we were short staffed. So it's crazy because hospitals were bringing travel nurses, and travel nurses were leaving their units, causing staffing issues on their units, going on different units to become travel nurses to fix short staffed units. So it didn't do anything. It just moved nurses around certain areas.
And same thing, I love reading comments that we get from the podcast and everything. So someone commented on YouTube or Instagram that their administration always gave them food. So someone made an anonymous note, don't give us food, give us nurses. Like you need help.
Yeah.
And we're still not filling the gaps. And it's so sad just thinking post 2020, the year of the nurse. The year of the nurse is 2021 too, by the way. We haven't fixed anything with nursing. We got some food, we got some appreciation from news, and we're heroes, and we wear caps, and that's it. It's like the veterans, almost in a way. We just got dumped on. That's it.
And throw in and subtract all the nurses that decided to retire before the pandemic hit.
And they did.
Yeah, and I'm not blaming them or anything, but I'm saying that's a smart move on there. I would have done the fucking same thing, but that caused a shortage, right? So imagine they were allowing student nurses, they're allowing them to do a little bit of things outside their normal practice to help out. Like CNAs were doing things that are a little bit outside their practice to help out. Some people were bending, they were definitely bending corners during COVID, for sure. And we had to fill the gap somehow. And I mean, we tried, and this is what happened.
And what's a crazy perspective about this is the nurses were doing this outside of their license. We're putting our license at the end of the day.
I mean, everybody was. Physicians were.
Yes.
Respiratory therapists were. Everybody was. And I guess it just shows you when shit goes south, like people are gonna get shit done.
And we're so resilient.
Low key or not, like. It's crazy about humans is when we need to get something done collectively, we get it done, and we don't ask certain questions. We don't talk about it, which that could also be an issue at sometimes because that doesn't allow much room for change. How to make this issue different in the future.
Very great point. Because we adapted as nurses, we're very resilient. We adapted to the stress and everything, and we held. But administration didn't change. They didn't need to because we bent. And if you think about it that way.
And it sucks because we had to.
And you got the short end of the stick like always.
Yeah.
The little people, right? It's the little people.
I wonder what's gonna change. Like it's crazy. It's still mind blowing to me that California could have these ratios and these kind of nursing units and this kind of functionality in the hospitals, but you can't have this anywhere else. Like, how does it make any sense? How can California implement this, but nobody else can?
And they've been doing it for over a decade.
Like someone's gotta be lying about something here, for sure. Someone's gotta be lying about something.
The American Hospital Association.
It has to, because there's no way, because this is like almost an ideal model, right? I'm satisfied where we work.
I'm happy.
Right?
There's break nurses.
Right.
There's mid shifts. There's ton of resources. They're always stacked when it comes to nights and days, like the CNAs in this hospital. Even in the previous one we worked at, it's great.
Yeah.
Even when we traveled to Oakland, when I was in San Diego, same thing. There is short staffing. That's just the reality, right? Nursing struggles, but there's resources.
Yeah.
In California, that's why we're here. It's great money, and you're not freaking suffering and drowning.
Right. How's that possible? Tell me, this is like a giant joke or some shit, but We're gonna try to get to the bottom of this. We're gonna try to get to the bottom of this one.
And I'm passionate about it, and I'm down to lead this, a movement to get that done. Like, it should be done on a national level. Come on, it's 2021.
Like we see it works. It's like an experiment that's already proven to be true, but some things like hindering it from being known.
And it's funny when we travel nurses travel from different states. They always say that California nurses have no idea how well they have it.
Yeah.
And it's true.
Isn't that crazy? Isn't that crazy? California has the best climate and the best nursing. What are we doing? I'm never having a winter ever again in my life, except maybe Alaska.
In Alaska.
We gotta go to Alaska.
And the next thing is nursing isn't black or white. The textbook teaches you for the fine lines for the most point. End of life care, they kind of teach you about ethics and difficult decisions. So that's true, that happens. I've dealt with these patients all the time. There's ethic committees and there's tough choices with death and dying. And just overall nursing is not black and white, meaning every experience, every single shift is different. You're going to encounter different things. Let's just say you're giving cardizem to this patient. Well, this patient might get affected differently. It's always going to be a different experience. And you always have to be on your toes, thinking critically, assessing the situation, and acting fast.
Yeah, and even nursing care-wise, it's not black and white. And no textbook doesn't say anything about a nursing bolus or a quick 250 bolus.
Yeah.
Right? You don't see that like anywhere. But it's just sometimes you just gotta do these things. And that's just how it works. But it's...
I don't want to even talk about nurse dose.
Yeah. Sometimes you just have to give a little bit more Ativan, and it just happens. Just because, it doesn't fit the numbers, but the way the patient's acting is he's gonna get whacked. He's been progressively getting worse and worse and worse just because it's not hitting numbers right now. I know he's going to in the next 15 minutes, but I'm not going to be able to administer anything in the next 15 minutes. It's not going to be enough. And you just got to give it. And then everyone's happy.
Yeah, and we don't do any of this stuff in this hospital. This is just hypotheticals, just for legal purposes.
Yeah, hypothetical situations.
And nursing is a trip. Like, I'm excited for anybody that's listening that's about to be a nurse, that's maybe nursing. You guys felt this out.
Yeah, but definitely being an actual nurse is a lot funner than nursing school.
100%.
Right, respect.
Jinx.
Respect, right there, dude.
What do you want? Soda?
I think of water. I think
okay,
cold water. Water, what's in my...
Cheers, man.
Yeah, cool. Gotta be healthy, gotta stay clean. Man, trying to cut weight, I'm just chilling, but we gotta be healthy around here. We gotta be well. But yeah, nursing is a lot better and a lot more fun than nursing school. It's a lot more fun than clinical, because in clinical, you can really do certain things, and the instructor had to watch you, and you couldn't partake in all these festivities or activities or the different care styles or emergent situations.
And you never felt like you fit in because you were the student.
And we had to be careful.
Label, and you had to be careful, and you were watched. And
you don't see actual nursing culture, because especially on nights, the culture on nights so much better than the culture on days. I'm gonna tell you that right now. Like, nights were rowdy people.
Yeah.
Days a little bit more calm, more proper. And
we had I had this conversation with a night shift nurse, and he explained it the same way. Because he got on a shift with this guy, and they were kind of like, they're messing around, like hardcore. Like, I almost thought they were serious at one point. I knew they weren't, but they had to explain it to other people because they're just, night shift is tight. There's just something about the night shift nurse. And we kind of brought it to days that were just messing around with people.
Yeah, we definitely got the vibe for sure.
I just hate how being a day shift nurse, you have to kind of be careful with management. I've never had to experience that where I felt like it's not a good idea to be on my phone. Because if I finish everything on nights, there's no family.
Right.
Because of COVID and they're not staying over still. There's no really management. The charge nurse is not going to say anything. I'm doing my damn job. And you're chilling. But here it's like, yes, you're having a break. And you have to be careful because that's your management.
Right.
They might say something.
Yeah, they might. The thing is, like,
if you're bored, they'll find you something to do.
Yeah, they probably won't care. But if it becomes like an occurrence, might be an issue and stuff like that. Like they might not care, but just
it's more professionalism more than anything.
Exactly. Yeah,
I do it for that.
Yeah. If you don't see her on her phone, you should try not to be on your phone. Yeah, you can take a peek at it once in a while, but just don't be scrolling through stuff or doing some posting for no reason.
Watching the TikToks.
Yeah, watch some TikToks. Man, you making TikToks? Man, I started an OnlyFans account pretty soon.
Bro.
Dude. I had to tell him.
I had to tell him, I'm not doing one. Yeah,
he's joking. We're just joking.
Modest, I'm modest.
You're modest.
Yeah,
Man.
we should do a comedy. We
Yeah.
can do it. We could totally do a comedy skit.
Yeah,
if
we
you
should
guys
wrap
are
it
interested.
up before you said stupid here. You know
Yeah.
what I'm saying?
This is a late night recording, 1 a.m.
That's
so,
laughies.
and it's funny because we're talking about night shift, and yes, we're hardcore night shifters forever because it's 1 a.m. We're doing a recording.
Yeah.
You just have to do it.
Yeah. All right, guys. Well, it's been a pleasure. Hopefully, your episode. We talked to you guys about the differences between nursing school, clinical, and actual nursing. Pretty interesting stuff.
And some good humor. Don't forget, we are Frontline Warriors. Stay tuned. Cupanurses.com for show notes and any updates. See you guys next week. Thank you for listening. Peace.
Bye bye.